Hello, this is Jessica May, and the study I will be presenting is the reenactment of childhood sexual abuse in maternity care, a qualitative study. The research problem for this study in particular is to navigate what the triggers are for childhood sexual abuse survivors that come with pregnancy and childbirth. It evaluates insensitivity in healthcare professionals that can enable reenactment of past abuse, and it addresses whether or not being properly informed about child abuse and taking universal precautions can help lessen the occurrence of reenactment in childhood sexual abuse. The sampling method, this study was conducted by any woman who attended the NHS Trust in South England, who openly disclosed that they had received unwanted sexual exposure before the age of 16 and who were currently over the age of 18. 23 women were offered packets asking for participation in the study, of which only 10 replied with interest and intent of participating. One woman dropped out of fear of emotional distress by being in the study, and that left a sample size of 9 women who participated. The reason that all the women were from the NHS Trust was so that their medical records could be accessed by the people, by the researchers. The study design, this was a qualitative study. All of the data was collected via a semi-structured in-depth interview. Most of these interviews lasted 60 to 90 minutes long. One was even 4 hours. This allowed for free discussion on the woman's part, and occasionally some prompting was given in case the woman did not have an idea of where to start or was at a loss for words. A review of their maternity care records was also conducted to find consistency in between their testimonies and their records, and the data was analyzed via the voice-centered rationale method. It was conducted by the author, discussed with the research team and consultants, and then the voice recordings were deleted for confidentiality for all the participants. So what did our study find? The study found in particular that for these 9 women, there were 5 subjects that encompassed their triggers, and that was the pain. The pain was often associated with the pain of their child abuse. Loss of control was a huge overall theme for all of these women's testimonies. Encounters with strangers, of course, we all know that in the healthcare facilities and even sometimes in midwifery care, having someone come in and out, someone they don't know and someone they don't trust, can be very triggering. And of course, there are a whole bunch of unexpected triggers that nobody could ever be fully prepared for. Anticipating these triggers had no effect on their ability to encourage reenactment or discourage reenactment of the participants' abuse. Some of these women went in fully expecting these triggers to happen, and others had no clue that it was going to come about. Only 3 of the 9 participants even disclosed their abuse to their providers, leading to the conclusion that providers are going to battle silence, that childhood sexual abuse will not be easily disclosed, and therefore being prepared for dealing with it is not a feasible approach. Indicates that reenactment of childhood sexual abuse is not a result of crossing personal or bodily boundaries, but is more about the approach taken by the care provider when performing such procedures. Care providers do have a tendency to compartmentalize and treat their patients just as a body or another object, and this approach can often be what is triggering for these for these women, mostly because they feel out of control. They feel like a subject, and they are not often vocal about this. They will suffer internally. Enabling women to have the ability to retain control and having a trusting care provider can help lessen the amount of reenactments that occur. And that was a common theme found in all 9 testimonies, that as long as the woman was able to retain control, then she felt safer. Further study questions that need to go on. Of course, there's the obvious. There is not enough research about this topic, and more needs to be done. Some questions that we need to answer is, what are some universal precautions, not probations, I'm sorry about that healthcare workers should put into place to help mitigate trauma. An analysis of trauma-informed practitioners in the field needs to be done. Does being trauma-informed help? Are there practices that we can do that are helpful? Are there practices out that are being used? Are they being helpful? A step-by-step training for incoming healthcare professionals on caring for the sexually abused. What are some precautions that healthcare professionals can take to help mitigate trauma for survivors of sexual child abuse?